Okay, and good morning and welcome to the Davies Use Case webinar being presented by TriHealth on optimizing strategic payment. This is the Davies award-winning use case for the value of health IT. My name is Arnold Simmons and I'm the Manager of Quality and Patient Safety at HIMSS, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology-enabled patient safety tools for healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes the outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speakers for today's call from TriHealth. And Donna, I will turn it over to you. And you can start when you.
Great. Thank you, Arnold. We're really excited today to share our story of excellence with you. My name is Donna Peters. I'm the Director of Information Systems over the Application Solutions Center. Been with TriHealth for about 20 years, and I'd like to tell you just briefly a little bit about TriHealth. TriHealth is a four-hospital acute care hospital system in the greater Cincinnati area. We have about 900 adult staffed beds, one short-stay surgical hospital, 3 freestanding outpatient surgery centers. From an outpatient location perspective, we have about 140 locations, 150 physician practice locations, approximately 850 employed physicians, 1,800 physicians on our medical staff, and a little over 12,000 team members. TriHealth is really proud of the awards that we've received related to clinical quality, technical excellence, and employee engagement. We're a 2-time Magnet recognized hospital. Most recently, we received recognition from Watson Health as one of the top 15 health systems for 2018. We've won Healthcare's Most Wired 7 consecutive years in a row, including 2017, as well as other engagements related to best workplaces in Ohio, Working Mothers Best Places to Work, and top 50 best hospitals in America. We received our original HIMSS Stage 7 designation in July of 2014 and most recently recertified that in December of 2017, of which we're extremely proud to be recognized by the HIMSS organization. At this time, I'd like to turn it over to Dr. Lorraine Stevens to begin our presentation on optimizing strategic payments. And Dr. Stevens, I'm going to turn this over to you and make you presenter.
Good morning. I'm Lorraine Stevens, and I'm delighted to be able to talk to you about our OSP program at TriHealth. I'd like to give you a little bit of background to begin. And so I'll talk to you a little bit about the value-based contract and population health. So when our leadership enters into a value-based agreement with a payer, it means that we are presented with a population of people, of lives that need health care. And there is a continuum along that really involves learning about the population, who they are and what their medical needs are, and what we need to do to serve that population the best. And in order to do that, there is a process that we need to work through to really be able to identify the population and identify their needs. And so this presentation will speak to how we did that. It's I think, very important in terms of how we serve our patients It's one of the things that maybe when I went to medical school to be a physician, I didn't think about, but it is part of the way I want to practice medicine as a primary care physician. So our source of truth for quality, TriHealth had over 200,000 covered lives in our value-based contracts. We had over 50 quality measures that were in multiple contracts. The payer scorecards did not reflect the high level of care that we thought we were providing to our patients. And our organization's leadership believed that we were not performing well enough to really get paid for our services and what we were doing. There wasn't a strategy to really reconcile that gap between what the payer was providing and what we thought we were doing for our patients in our EMR data. There was a lack of data for the managed care team to take back to the table to negotiate with our payers to make these metrics in the contracts. And the other big challenge in this process was that the payers' data was retroactive, and we were looking at things that had already happened, so as far back as 120 days. And we realized that not all of the members that the payer was attributing to us in these agreements were actually in our electronic medical record. So we had a manual process that helped us to look at the gaps in care and also look at how we would contact a patient, reach out to them to help schedule preventive services, schedule physician appointments, making sure that our patients were getting the care that they needed. And this manual process was just not adequate for us to be able to grow our population health strategy and to be able to really bring population health and value-based care to a large number of patients, such as over 200,000. So we needed to do something about that. So this is where we started in terms of quality measures. Quality metric performance is something that in every value-based contract with a payer, the health system will have measures that they need to perform against. So targets that need to be met, and their patients will need breast cancer screening. They'll need colon cancer screening, among other things in here. So some of these measures are related to disease states. Some of them are just related to well care and preventive care. And so this is how we looked at that point early in the game when we were trying to assess what kind of services we were providing for our patients and where the gaps were and what we needed to do. So in terms of workflow and design solution, we had a multidisciplinary team, which included stakeholders from many parts of the organization that could have an effect on this process. We established goals and determined what metrics we would focus on. We started to look at leveraging our core systems in the organization to help be part of this solution. We looked at member and claims files from our payers, and our IT team looked at scaling our architecture so that we could serve a larger population. As I've mentioned previously, we did have barriers and challenges, the timeliness of the payer files, the member attribution, meaning who are our patients, and then reconciling that with what we have in our EMR with the claims process. As we implemented our solution, we had to train team members. We needed to start with quick wins so that we could engage our team. And then another thing that we had to work on was cleaning up duplicate patients so the patient could be listed in the system more than once. And we needed to clarify, were these different people, or do we have duplicate patients to clean up files? So for work group and governance, this was our team. These are the stakeholders in our organization that were represented on this team. So our physician hospital organization and managed care. We have primary care leadership And we had the contact center, which is the boots on the ground force that contacts our patients to help schedule things like mammograms or colon cancer screening. We had contract compliance coordinators who were also working lists that would come from the payer with gaps in care. We used care coordination to help, and that care coordination force is something that also is kind of a boots on the ground in working with the primary care practices to help patients get the best care that they can get. And then when needed, our revenue cycle folks would look at documentation and coding. And of course, IT was there to develop to design and develop a system that would make this work. And then this is just a little bit more specifics about our team and kind of our role in the OSP process. And as I said, TIFO, we organized our team efforts. We were instrumental in providing information to close gaps in care. Managed care would help facilitate obtaining the payer files, and were an integral part of the team in terms of that communication piece to the payers. Primary care leadership and care coordination, of course, so that at the point of care, this work could be done, and the call center and contract compliance to help reach out to the patients, and again, IT and revenue cycle. And so now I'm going to turn it over to Joanna.
Thank you, Dr. Stevens. Hi, my name is Joanna Sonnefeld. I'm an application architect with within our IS department, and I'll be reviewing the IT solution along with Holly.
Hi, I'm Holly Klingpack. I'm a solution lead on the data warehouse and analytics team.
So we're here to help present the IS solution that we came up with. So the first thing that we did as part of this team is we were told that since we're already doing this work, we don't want any additional clicks within the practices, right? So we're already doing it, so we need to come up with a solution that automates as much as possible. So as we went through the list of the wants and the things that we needed, we kind of grouped all of our solutions into 3 buckets. So our automation. So the first thing that we did is we added a BMI diagnosis directly on the claim. We wrote rules to look at the chart to determine what the BMI is, and then we added that diagnosis to the claim. That alone we were able to go from a 1-star rating to a 4-star rating within 6 months of just doing that. The next thing that we did is we utilized the function within our EMR to automatically drop the PQRS measures of the quality measures that we were doing. So we were dropping the CPT2 codes or a HCPCS code directly on the claim. That allowed the payers to know that we are doing these, and here was the result of some of our quality measures. We went ahead and had created supplemental data files to send to our payers. And then the last thing that we did was something that we found out kind of later on, was that the payers were truncating our diagnosis to whatever they could handle, so maybe it was 12. So to help with our HCC scoring, we went ahead and sent supplemental files to the payers with all of our diagnoses for our patients for a visit so that it doesn't get truncated. The next group of solutions that we came up with is we needed to be able to identify the new members per payer per contract so that we can know what we need to concentrate on from a payer perspective. We wanted to show the care gaps alongside the clinical data. So the contract coordinators, they were going into the payer portals, and they were seeing that they were saying we had care gaps. And when we looked in our EMR, there were no care gaps. We had addressed it. So this was to be able to bridge those two together. We wanted to show that information together in one screen so they really knew what was a true care gap and what was the care gap that needed to be closed by the payer. The other thing that we wanted to do was to show the new members. So as a contract came in place and these members were added to our contract, we needed to know who were our new members to bring them in for an office visit, for their first visit, or if they really weren't our patient, we needed to be able to document correctly in order to get them off our list so that we had a clean list of patients that we were working. And then finally, the group of solutions that we did was action. What did we need the team members to be able to do to be able to keep their lists clean and to be able to work on a daily basis? So we utilized some features within our EMR to be able to track those patients as they were doing their outreach, to be able to do bulk ordering. Let's say these were our patients that were overdue for an A1C, to be able to do in one click, to be able to place that order and have the provider sign it. And then we created what's called a smart step for ease of ordering for those team members. So this was the overall design that we did. So we have, starting on the far left, you have all the membership files, all the files that we receive from the payers. Our lovely data warehouse team would do patient matching, and they would take that information and we would update the patient with like what the payer said for a gap in care, or to make sure that we knew who were the members by contract. So that went into our Epic system. From there, we were able to know what those patients are to be able to close the care gaps based on by payer. So that was the registries that were built that were by payer, by measure. From there, they could do features within Epic like bulk ordering and scheduling. And then finally, as you go down, we took that information and we created a dashboard so that leadership knows where we are in the process. So these were the measures that we focused on. This was our first value-based contract, and these were the measures. These were our goals. So this was our intended outcome. This is where we were shooting for as part of this team. So you can see there's the first section is called the quality gate, and for this particular contract, you had to meet that measure in the quality gate. Otherwise, you were not allowed, or you did not have the you weren't eligible for the quality measures or the medication adherence measures. So you had to meet the quality gate first, and so that opened up the other measures. So we did a lot of focus on those quality gates to absolutely make sure that we met those measures. So this was the gap in care workflow that we came up with. So leadership needed to have some way of knowing what measures to focus on. Where are we in this contract for this measure? So we needed to come up with like a dashboard for them so they were able to communicate to the contract compliance people what measures to focus on. So when the contract compliance people, team members would know what they're supposed to do, they would go to their dashboard or their work list and they would start looking. So they were able to look by payer and say, from the information that we were able to give, does the payer think we have a care gap? And if the answer is yes, do we have that information in Epic? And if the answer is yes, then they print off the necessary documentation and they would upload it to the portal. If the payer doesn't say we have a care gap, but we say there's one in Epic, then we would call the patient in, we contact the patient, and we would bring them in for that visit or for that test that they needed to do. The contract coordinators, we had to give them a tool, like I said, to be able to track who they've called. If the patient refused, we wanted to be able to track that. And then if the patient had the test done or the care gap completed, but we don't have it in our EMR, then when they contacted the patient, they needed to be able to grab that information get that information from the patient, so we were able to upload it into our EMR and close the care gap on the clinical side. As we go through, our new member workflow was we received the membership list from the payer. The contract coordinators would make that outreach to the payer. They would try and reach them 3 times. This is really based on the contracts that we had on the necessary documentation to say if this patient was a member of ours or not. So we needed to have a tool that they were able to document the necessary outreach to be able to determine if the patient was ours or not. And if they were, then we would schedule the visit. So this is the dashboard that we came up with. It looks a little busy, but it's actually, at a quick glance, you can see what's going on. So from the far left, we have the filters. So they're able to filter by contract and even down to the payer and then down by the measure. The tree map in the middle, the blue boxes, those show our opportunity. So the bigger the box is the total number of gaps. The darker the color is the amount of payment that could have for meeting that measure. So really quickly, you can see from here that hemoglobin A1C is a metric that we would want to focus on. This is what our leadership would use to determine, what measures we want to focus on for the contract coordinators so that they can start closing those gaps in care. The far right, where it has the green and the red, those actually show the number of patients that we have to bring in to meet the measure. So the red is the gap in the patient's chart the number of patients that need to be brought in to meet the measure. So at a very quick glance, they can filter through this and then see what we need to focus on and which patients we need to bring in. This is the payer registry dashboard that we created, and what this is so as the leadership was looking at the dashboard, the previous dashboard, so let's say it's mammograms, they would go in here by contract, pull the mammogram report up, and that would be the patients that they would want to work. So this is what the report might look like. And so the really important part about this screen is the red X's. And what the red X is, that's the information that we got from the payer. So we brought that information in, we're displaying it and saying the payer thinks that this patient has a care gap. And then this column right next to it is the last mammogram date, and that's how the contract coordinators know, is this truly a care gap, or is this, if we have the information, we can go in and send that to the payer. If it really is a care gap, then we need to go ahead and bring those patients in. They have the ability to filter on this report, so they can filter out those that really, if there is no care gap, they can filter those patients out. The next part of the tool is documenting the outreach. So within that report, they can click on patient outreach. From there, they can document if they've contacted the patient. So this is where they would say the patient refused, or they said that I contacted them and I need to contact them in a week, so that they can keep their list clean on who they want to, who they're calling for the day. And those items show up in the column that's circled here. So they're able to, once again, filter on those or know who they need to contact, who they need to do their outreach on. Once they have that list, and they can go ahead and do a couple features. So we've made it actionable. So they can generate a letter to say, these are the patients. They can highlight those patients that are overdue for a mammogram. They can create a letter from there, and that letter would say, it's time for your mammogram, here's who you need to call, and they can start doing outreach based on a letter, so like a batch lettering. The other thing they can do is for a bulk order. I mentioned that before, so let's say they can highlight the patients and say, for our diabetic patients, these are the patients that are overdue for hemoglobin A1C. They can click here, and just a couple clicks, they can sign those, and they can send those over to the providers, and they can sign those orders. Finally, we created a smart set, and this was just one place that when somebody is calling the center, if they know that this patient is one of our value-based contract patients, and they would look on what care gaps they're left open, and we created a smart set for them, so while they're on the phone, they can very quickly make the orders while they have the patient on those items that they have a care gap for.
This is our new member dashboard. It serves two purposes. One is to identify members that are new to a plan that may need outreach to get them in for that first scheduled visit. The other is our patients that were attributed to us, the members that were attributed to us that aren't yet patients. This dashboard allows the contract coordinators to search by specific contracts or search by other, and then sort it by other information in order to make that outreach.
So we utilize that same tracking tool that we used, what I demonstrated in the mammogram. So they're able to document how many times they've contacted the patient, because like I said, some of the contracts you had to at least try and have 3 touches to contact that patient. If you're not able to contact that patient and having the correct documentation, that would be something that the PHO would use. They would give that information to the PHO or to managed care, and they would go ahead and have those patients removed from our list, our member list. And I will pass this back on to Dr. Stevens.
Okay, so now we're just looking at some information just to measure some of our outcomes. And this was a way of looking at how the contract coordinators were using the tools that had been created. And you can see that from 2016 to 2017 that we did see an improvement in the use of the tools. These were our quality measures, and you can look at our performance years and see the improvement over time. With the increased use of our tool, we were able to improve our performance. So in terms of, I'm going to talk about financials here. And I just want to preface this by saying it may seem like, you know, this is all about the money in terms of performing in these value-based contracts, but and it is about the money, but not in the way you might think. It's about the money because this is how we pay for health care. This is how we take care of the patient and how we can continue to provide care for them. And so it really is, even though this is put out in financial terms, I think it's a way of showing that we are taking care of these patients and providing services that are very important for their care. So if you look at 2016 over 2017 and the totals, you can see what the improvement in contract performance and the financials that are related to that. So in terms of another outcome, this is our first value-based contract payer, and this is, again, performance from 2016 to 2017, showing just the incentive payments and the growth in that payment. And then again, this is the use of the tools in terms of the incentive payments. Okay, I'm going to show you a couple of cases here where we actually used the tools that we developed and applied it to a preventive service. So the first one is colon cancer screening. And you can see that we improved our colon cancer screening. What we did is we offered FIT DNA testing, and in order to population that we screened in our value-based contract. So not all patients are able to or are willing to get a colonoscopy. So that's the desired test. If we're not able to get that done for the patient, then there are alternative tests that we can apply. We used our tools to apply that, and as a result, we were able to detect colon cancer in 2 patients and provide services to impact their lives. And this is a case for breast cancer screening. It's kind of the same thing. We applied some of the tools that we developed to increase the population of patients that were screened by mammogram. And we were able to screen an additional over 700 patients in this process. So, and then this is also a case for the diabetic eye exam. We developed a close relationship with our community vendors who provided eye care for diabetic patients. We were able to develop an interface that directly interfaced with our EMR so that the results for the patient's eye exams would come directly to the chart, and we could increase our population screened, increase the number of cases of retinopathy that were detected. So in terms of return on investment for our OSP process, we increased our incentive payments. We reduced costs for the manual process, which is a big win. And then in terms of cost avoidance for diabetes care and management, for colon cancer avoidance, and for breast cancer avoidance. So the total ROI is there in the right-hand corner. And it's over $7 million there. So now we are expanding our OSP process. We are growing our population. So we are, in this slide, we're at 225,000, I believe, and counting, continuing to grow that population. We're able to take on more value-based agreements and manage those contracts more efficiently. And we were able to step up that schedule to a shorter time frame than we thought we would be prior to the development of the OSP process. We have been able to provide tools back to managed care so that they can drive negotiation discussions in these value-based agreements, and we're able to properly identify our attributed patients in these populations so that we can actually reach out and provide care. Is the second payer in our population, again, a summary of the financials and the performance year over year, as well as the total earned for these contracts. Project outcomes, again, we increased attributed lives against the incentive payments, which also grew as the lives grew, and we increased, and this is the Medicare Advantage, this top graph is the commercial population. And again, this is just another way of showing the increased use of our tools and that our performance measured in incentive payments did improve over both contracts, commercial and Medicare Advantage, in this second payer agreement. So keys to success and lessons. We had a culture where we created a partnership with all of our stakeholders that could contribute to the process. Information systems was part of that team. We worked together. We developed quick wins. We brought our process to maturity. The OSP process is now being elevated in our population health structure, and we are continuing to grow that process, and it will help us to become more efficient and bring our value-based agreements to a more mature process where we're taking care of a larger group of people. And then this is just our lessons learned. So stay focused on the why and communicate it often to your teams. Involve the physicians in the process and help them understand why we're asking this, why it's so important. In the challenges that we have in working with the payers, helping them understand what we're doing and that we can participate in a high level. Managed care is an important partner at the table so that they can also communicate back to the payers, that they understand you know, our processes and what we're doing and how we're managing these contracts and bringing health to a large population. To completely examine the quality measures, what they mean, how they're defined, so that we can focus our efforts on success, and so we can maximize any operational pieces that will help us meet those measures. And then, you know, looking at the information from the payer, comparing it to our own information was a key process in trying to understand our performance and how we were measured by the payer. So what's next for our OSP process? I've already mentioned that we're elevating this process into the population health structure. I can maybe ask my colleagues to join in for some of these other items here in terms of epic optimization and the daily practice operations.
Sure. So for the epic optimization, the member matching that we were doing was an algorithm that we did outside of EPIC. EPIC actually has a feature called roster management that helps us do that member matching within from our clinical, from their EMR, from EPIC to the payer files, that membership files that we were getting. So we were able to utilize that feature. That also helped us put who the payer says is the attributed provider, so we're able to store that on the care team. So we'll have some additional results or reports and some other features that we'll go ahead and take advantage of once that's done.
And then we're loading the claims files directly into Caboodle, and we'll be able to use those claims for additional reporting and incorporating that into our HCC risk calculations. And then the other piece of it is the cost and utilization dashboard, which sits on top of those claims files that are in Caboodle that will be surfaced up to the end users for analytics.
And then we talked about having the practices start engaging more and expanding it out past our contract coordinators.
This slide just looks at some of our recognitions and wins that we have accomplished along the way. So one of our payers has named us as the top performing commercial ACO, and we also have, I think, based on the information we have at this point, we have earned a large percentage of the value-based revenue that's available for us at this point in time for this year. Excuse me, that's the 2017 performance year. And then this is our wrap-up. So we've reviewed some of this already, but again, our problem was that we had a large population of patients to manage and provide health care for. We were not being paid based on what we thought was our performance. We developed a system using all of our stakeholders and designing a process that would help us to capture that information, in addition, bring additional services to patients who needed them. Our IT tools, as mentioned before, the data warehouse, our patient attribution engine, and our registries, and then our standardized and discrete documentation and our reporting dashboard to monitor our work. So in terms of value, we met all of our quality metrics 2 years in a row. We increased our incentive payments. We increased patients receiving colon cancer screening. We increased patients receiving mammogram screening. And we increased the number of diabetics who were getting their annual eye exams. And I think that's it, unless there are additional comments to wrap up.
Okay, thank you. Thank you all for joining us for this Davies webinar today. I would like to remind everyone more Davies use case webinars and information on how to apply for Davies Award can be found posted at the HIMSS Davies Award website at hims.org/Davies. Once again, thank you so much.